Today we will discuss basic concepts of unicystic and peripheral ameloblastoma along with multiple choice questions. Now, the term unicystic ameloblastoma is of two terms, that is unicystic and ameloblastoma. Now, why the term unicystic? It is a cystic lesion, a unilocular radiolucency can arise from dentigerous cyst, and clinically it also resembles dentigerous cyst. But histopathologically, it is not similar to that of dentigerous cyst. It resembles ameloblastoma. Why? Because the basal cell layers are tall columnar and which are reversely polarized. Unicystic amyloblastomas clinically behave like a swelling which is asymptomatic and without pain or neuralgia. The location is in posterior region of mandible. It is a benign lesion and it appears as a well circumscribed radiolucency radiographically. So there is a unilocular radiolucency seen mostly in the region of molars. Males are affected more than females, and the swelling is slow and gradual. Now, it differs with dentigerous cyst mainly in histopathological aspects. It doesn't have an epithelial cell layer, which is similar to that of dentigerous cell layer, but a distinct epithelial cell layer is seen, which consists of columnar basal cell layer, which has got a hyperchromatic nuclei with reverse polarization, like that in solid ameloblastoma. Also, vacuoles are seen in cytoplasm. Unicystic amyloblastomas resemble dentigerous cyst both clinically and radiographically. They resemble solid ameloblastomas histopathologically because the basal cell layer has reversely polarized nuclei and also there is stellate reticulum cell layer. The term unicystic was coined probably by earlier researchers due to its large unilocular radiolucency seen radiographically. The recurrence rate of 10 to 20% was seen after enucleation, and many studies indicate that it has got better prognosis than solid ameloblastoma. Histopathologically, there are three types of unicystic amyloblastomas. One is luminal, it has got a prominent lumen. The lumen is lined by epithelium, which has got a basal cell layer which resembles that of solid ameloblastoma. The overlying epithelial cells are similar to that of stellate reticulum cell layer seen in solid ameloblastomas. These are loosely cohesive and star-shaped cells. The intraluminal type of unicystic ameloblastoma has one or more nodules of cell layer which project in lumen. These nodules mostly show plexiform pattern. The mural cell type of the unicystic ameloblastoma has an epithelial cell layer which infiltrates into fibrous wall of the cyst. This variety needs long-term follow-up. This picture shows all three histopathological types of unicystic ameloblastoma. In this picture, we can see that intraluminal type of unicystic ameloblastoma is spread like as a rosette in the lumen, whereas in mural type, nodules are seen in fibrous capsule. So to conclude, unicystic ameloblastomas are 10 to 25% of intraosseous amyloblastomas. They are common in second and third decade of life. They may arise from neoplastic transformation of cyst, and recurrence rate is less than solid amyloblastomas. So to conclude, some multiple choice questions. Question number one, not true about unicystic amyloblastoma. C, number one option is correct. It resembles dentigerous cyst radiographically. Option number two is also correct. It can arise from dentigerous cyst, which is one of the important etiopathogenesis of unicystic amyloblastoma. Option number three, asymptomatic lesion. Again, it is a correct because mostly, unless affected by some other inflammatory conditions, it is largely asymptomatic. And regarding option number four, it is wrong because unicystic amyloblastomas have good prognosis than solid amyloblastoma. So, not true is bad prognosis than solid amyloblastoma. Question number two, unicystic amyloblastomas, true option, seen more in males than females. Yes, it is correct option, seen in old age. No, it is seen in younger age. Second decade and third decade of life are affected, seen more in anterior region. No, it is a wrong option, it is seen in the posterior region, molar region. And option number four, no, it is again wrong, it is unilocular. So out of these, the true option is option number one. Regarding question number three, unicystic amyloblastoma, option number one, intraosseous lesion, this is a correct option. Option number two, extraosseous, no, it is not an extraosseous lesion. The examples of extraosseous unicystic extraosseous lesions are peripheral ameloblastoma. It is not a malignant lesion. It is not seen on dorsum of tongue. Question number four, which of the following is not histopathological type of unicystic ameloblastoma? C, mural, intraluminal, luminal are histopathological varieties. But desmoplastic is not a histopathological type of unicystic ameloblastoma. So correct option is option number A, desmoplastic. Chances of recurrence are the correct option is solid ameloblastoma. Unicystic amyloblastomas have got very good prognosis than solid ameloblastoma. Again, peripheral ameloblastoma after enucleation, they don't recur mostly. So option number A is correct, that chances of recurrence are most in solid ameloblastoma. This is again other multiple choice question. Radiographically, unicystic amyloblastomas do not resemble with. They resemble with indigenous cyst, they resemble with odontogenic keratocyst, they resemble with ameloblastoma. These are again three differential diagnoses of unicystic ameloblastoma. But fibroosseous lesions show mixed radiolucent radio-opaque appearance. So this is wrong option. So they don't resemble with fibroosseous lesion. Option number D is correct option. True about unicystic amyloblastoma. Option number A, better prognosis than solid ameloblastoma. Yes, this is the correct option. Regarding option number two, though no, they are radiolucent. Option number three, it causes facial neuralgia and perineural invasion. No, they are largely asymptomatic, and all of them. So option number A is correct option. Now coming to peripheral amyloblastomas. Peripheral amyloblastomas are seen in soft tissue regions of head and neck, mostly in the jaw. They are seen in gingiva and buccal mucosa. Now regarding the differential diagnosis of peripheral amyloblastoma, they resemble oral fibroma, pyogenic granuloma and giant cell lesions. So they resemble benign non-epithelial tumors of oral cavity. Histopathologically, large number of epithelial islands are seen in lamina propria. These islands resemble the islands seen in solid amyloblastoma, mostly that of follicular variety of solid amyloblastoma. Now, what are the common features? They are seen more in mandibular gingiva than maxillary gingiva. They clinically resemble a fibrous overgrowth. The recurrence rate is very less. There are lots of studies, but generally recurrence rate is very less than 20%. It is 5 to 10%, and prognosis is good. So this was brief about peripheral ameloblastoma. Now certain multiple choice questions. Peripheral ameloblastoma can arise from uh, important E2 pathogenesis of peripheral ameloblastoma is they can arise from B cell epithelial cells. They don't arise from restomelasis. Restomelasis, radicular cystis arise, and they don't arise from dental papilla or dental follicle because mixed odontogenic tumors or mesenchymal odontogenic tumors arise from dental papilla or dental follicle. So option number E is correct one. Question number 2, peripheral ameloblastoma does not resemble clinically with they resemble with oral fibroma, they resemble with pyogenic granuloma, they don't resemble with dentigerous cyst, and they can resemble, they have appearance similar to that of peripheral odontogenic fibroma. So option number 3 is the correct option. Peripheral ameloblastoma is not seen in, it is seen in buccal mucosa, it is seen in gingiva, it is seen also on alveolar mucosa, and it is not seen on the nasal bone. So option number D is the correct option. Least common type of ameloblastoma is peripheral ameloblastoma. It is only 1 to 5% of ameloblastoma. Solid ameloblastomas are most numerous types of ameloblastoma. Unicystic ameloblastoma is roughly 10%. Peripheral ameloblastomas are 1 to 5%. Again, conventional and solid are similar. Solid is also called as the conventional type. Correct option is C. Thank you. See you soon. Bye.